So it's still important to know the history about this patient. And in your care postoperatively, you need to be looking out for signs that they're going into a crisis event. Some of those signs are extreme complaints of pain. It's sometimes very difficult to manage the level of pain these patients experience. I've seen times where we have literally pulled a 50 milliliter syringe of Dilaudid that's normally used for a PCA pump, and a physician has literally stood by the bedside and pushed the medication into the patient until they have at least some kind of decrease in pain. So these patients can take an inordinate amount of narcotic dosage. Average person could not survive. Let's just put it that way. They'd go into some kind of respiratory arrest if we gave them the same amount of narcotic medication. Oftentimes, the best way to manage these patients' pain is to go ahead and put them on a PCA machine and allow them to initiate their own pain medication when they need it. That's a safe way for them to administer their pain medication. Otherwise, you as the nurse are probably going to be called into that room very frequently because their pain is not being well managed. Crisis events does require hospitalization because not only because of the pain issue, but also because of the risk of hypoxemia, the risk of the lack of oxygenation that these patients will experience. Your job is to monitor their oxygenation. Notify the physician if the SpO2 is falling below 94, 95%. Most of the time, you'll have oxygen orders where you can use a nasal cannula, simple face mask, deliver oxygen. But if they require higher concentrations of oxygen, you may have to reach out and get those orders for that patient. These patients may need to go into a higher acuity setting, like an intensive care unit, if we cannot oxygenate well enough or even treat pain well enough on a medical surgical floor. Because of the sickled cell and because of the occlusion that can happen, they are high risk for blood clot formation. So think about DVT prophylaxis. If they're not up ambulating, we definitely need to put SCDs on these patients to try to prevent blood clot formation while they're in bed. They also may be put on some kind of anticoagulant, maybe a low molecular weight heparin, something like enoxaparin that will help prevent DVT, but they're going to weigh the risks and the benefits and decide what is appropriate for that patient. Sickled cells, think about them occluding or getting stuck. Well, if we hydrate them well enough, then maybe it makes them a little bit more slippery. It makes the blood a little bit more dilute. And so you may be asked to give boluses of IV fluid, certainly keep them on some kind of maintenance IV fluid, and maybe even encourage PO fluids to try to keep them well hydrated. Aplastic crisis is pretty much all of the blood cells being low, red, platelets, white, and so they may need transfusions in that case. Oftentimes that's going to be packed red blood cells. It could be a transfusion of platelets if their platelets are too low, but we really can't bolster white blood cells too easily without just administering medications or giving the patient time to make their own. Certainly, if they are aplastic, we need to help prevent infection. They are going to be more susceptible to infection. They're going to be considered immunocompromised, and you're going to need to put them on reverse isolation to protect them from getting an infection. A drug called hydroxyurea basically increases fetal hemoglobin, which alters the adhesion of the sickled RBCs. So that could be something that they will use as well. Okay, so polycythemia, a little bit similar but different. So basically, let me go back. So basically what happens in polycythemia is you have too many red blood cells forming. Polycythemia vera is considered a genetic condition. Some of the natural ways we can become polycythemic, we could go live in upper elevations, Denver, Colorado, which is considered the mile high city. Our bodies will recognize a lower oxygen concentration up there that we breathe in, and so our bodies will stimulate and reproduce more red blood cells so that more red blood cells can carry more oxygen. So you see a lot of athletes, especially training for the Olympics, will go and to higher elevations to train to cause their blood cells to reproduce faster and to accumulate more of them. Gives them an edge because they can, stimulate their red blood cells to carry more oxygen and hopefully perform better. Polycythemia that you might see in the hospital, we don't really see this often as a problem. However, our COPD patients, which we'll talk more about this afternoon, our COPD patients can naturally become polycythemic because they have a decreased oxygen concentration in their blood due to their disease. Their body tries to compensate for that by producing more red blood cells, and that's basically how they do that, is stimulating the kidneys to produce more erythropoietin. Erythropoietin will stimulate the bone marrow to produce more red blood cells. And as those blood cells populate more, the idea, at least in the body's compensation mechanism, is to get more blood cells to carry more oxygen. So COPD patients you could find having polycythemia as well. If you think about more red blood cells circulating, you think about that blood being more viscous or thicker than average blood. And that could pose a problem. It could increase the risk of clotting. It could cause issues of circulation, especially if all of these red blood cells clump together and basically form a clot where blood cannot bypass it and get to the distal areas. So think of your smaller vessels that might do that, the hands, the toes, the feet. Okay. So I basically talked about each and every one of these. Polycythemia vera is that genetic component. Secondary polycythemia, think about your COPD patients falling into that category. So clinical manifestations, these individuals' blood pressures can be higher because of the extra red blood cells that are circulating, the viscous blood that causes. They can experience headaches, dizziness, vertigo, ringing in their ears, visual changes, heart failure, even angina because of the coronary artery that might be blocked, and stroke. You'll see these, and I'm going to go ahead and finish this, so I apologize for ending a little bit late, but I don't want to disrupt because I think we're almost done with this. So polycythemia manifestations, you might see bruising on these patients. Petechia, which are your kind of small pinpoint bruise kind of dots, but it can expand into a larger bruise like you see in this image. People can have nosebleeds, GA bleeding. Certainly their spleen can become enlarged, their liver can become enlarged. And due to the excessive destruction of RBCs, it's going to increase uric acid levels, which makes you think about gout. These are the lab values. So if we drew blood samples, their hemoglobin and hematocrit levels will be elevated. How we deal with this is a lot of times on an outpatient basis, they'll come and get maybe 500 milliliters drained. It's kind of like they're donating blood, but they're not really donating blood. They're pretty much getting rid of the excess blood through phlebotomy. So they'll get about 500 milliliters drained off, and they have to repeat that every few weeks to every few months, depending on how fast the red blood cells are going to increase in their blood. We can give them IV fluids to decrease the thickness or the viscosity. We can ask them to drink more fluid. We can give medications to suppress the bone marrow from producing the excess red blood cells. If they are increasing their uric acid levels, and you think about gout, allopurinol is the same medication to treat gout, it could be a medication to treat uric acid levels in this patient as well. And then to prevent blood clot formation, think about those that are antiplatelet. That could be aspirin, that could be Plavix, that could be Pradaxa, that could be a number of medications on the market to reduce blood clot formation. That's it. So any questions on those slides? And that gives us all day to do respiratory.
I had a question about the phlebotomy.
Sure.
When they're doing that procedure to remove, say, 500 cc's of blood, are they also going to then replace them with IV fluid or something to keep the volume high, or they're...
Not necessarily. So we can lose about half a liter of blood, which is 500 milliliters, and not suffer from it. They might feel a little fatigued. They might feel a little weak afterwards. But if you've ever donated blood, you're giving anywhere, if you're donating whole blood, sometimes they're taking 300, maybe close to 500 off of you. And they just tell you, eat, drink, rest. But typically, for the most part, they're not affected to the degree that they would need anything replaced.
But the remaining blood still has the same density of red blood cells.
Well, if you lose blood, it would span out. The body would take care of it and it would kind of span out. If you kind of think of it all clumping in one, if there's less volume by taking that excess volume away, it's kind of going to diffuse, for lack of a better description, I guess.
Professor.
Sure.
So going back to what Ms. Clay is saying, so I really had a very bad experience. I was doing testing for one of the patients, and the hematocrit was around 88.
Wow.
So the patient died. And so my experience wasn't very good. So the problem that I encountered at that time, it was the fact that the emergency room did not know what to do with this patient. So one of the things that happens to them, or that happened to this patient, it was that he showed up around 2 a.m. in the emergency room. Or actually, correction, it wasn't 2 a.m. It was around 8 p.m. So what I understood the next day when I found out that he passed away, because they sent him home and they didn't take care of him, or I think it was him. It was the fact that at 8 p.m. there's no places to do to take blood or to do. I was told that those procedures are done by dialysis nurses.
Oh, you mean to take blood out of them?
To take blood out of them in the emergency room. They didn't have dialysis, especially in Woodland. So that's where I was working. And so that's just kind of a very unfortunate situation. Now, learning how to do this and it was a slap on the face when my boss said that I could have called blood source to make arrangements for the patient. And I'm like, how am I supposed to do that? I'm not a nurse. I'm not a doctor. I'm just a scientist. And so that was another unfortunate situation. I really don't know whether blood source or other places actually really have services to do dialysis or phlebotomy at that time of the night. That's a real challenge when it comes to not knowing what to do with the patient. And if I was a nurse and I was the one in the emergency room, I did not know it. I wouldn't know what to do. And the answer to my boss wanted me to phlebotomize the patient using...
Hey, I'm sorry to jump in here. Can those of us who have to go for lunch purposes take off?
Oh, sorry.
Okay.
Go right ahead.
All right. Thank you.
Go ahead. So anyway, I would not know what the solution is for that matter. So I don't know. I was wondering what's the right solution when you find somebody has a hematocrit of 80.
A lot of times what you're going to encounter is a systems problem. So what you're describing to me is like a hospital systems problem. And there's a lot of hospitals that are in community settings. They're not teaching hospitals. And so you're describing kind of one instance. I can give you another. Let's say somebody is experiencing, cardiac issues or even COVID, for example, and they need to go on something called ECMO, which is kind of a life-saving alternative to improve their tissue perfusion and oxygenation and so forth. Yet those devices are rarely available in community hospital settings. You'd have to have somebody go to a teaching hospital where those devices could be available. So unfortunately, it sounds like the system that you were working in did not have the capability to manage this patient. Ideally, it would have been that the patient should have been transferred or recommended to go somewhere else that maybe could have the capability to treat him. You can never work out of your scope of practice. So even a nurse being asked to drain off 500 milliliters of blood would be something out of our scope of practice. That is reserved for trained professionals working in, say, a blood bank, or a trained professional working in the lab that could do that, or dialysis.
So that's the case. As my license, I'm allowed to actually draw blood, but it's for testing purposes.
Yeah, but draw blood and drain 500 milliliters are entirely
different story.
Different things. Exactly. So you couldn't necessarily intervene in that case. It's not to say that the patient would have survived even if you were able to drain off, because an 88% of hematocrit is extremely high. It's the highest I've ever heard of. And so, even giving, let's say, IV fluid to try to dilute the blood, you run a risk of overhydrating a patient too, and they can go into pulmonary edema and go into respiratory distress, and you can make situations worse by even trying to use IV fluid to dilute his blood, and it probably would have needed to be quite a bit of fluid to dilute a hematocrit of 88%. It sounds like maybe there were other comorbidities going on besides just a hematocrit of 88% that might have led to his death. So without knowing those, I can't speak to him.
Oh, it's that the heart could not stand it, and he actually he had a heart attack the next morning.
Well, I guarantee you that he probably had cardiomyopathy, because 88% doesn't happen overnight. And it is probably a condition that he lived with for quite some time. And so even if you, let's say, could get 500 milliliters off of him, I'm not sure that he would have survived, because his heart was probably damaged already, and he went into heart failure. And he probably lived with some kind of cardiomyopathy, which, again, we'll talk about next term what that is. And cardiomyopathy isn't something you can necessarily fix without a transplant.
Okay.
So chalk it up to an unfortunate systems problem.
Yeah.
But I think it's a larger issue than just not being able to drain, do phlebotomy and drain off excess fluid to get his hematocrit down. I think it was a bigger problem, and I'm not sure that anyone may have saved him if he passed within 24 hours.
It sure felt unfortunate, and I felt so frustrated. I can still not. I cannot forget about it. But anyway, especially when I actually end up having an argument over it with my manager, right?
No, definitely. And you are going to face some unethical situations in healthcare. There's no doubt. We have a lot of disparities in healthcare. And those disparities can be where you live, what your access to healthcare is, what your insurance will cover. And that's just the unfortunate lax side of healthcare in general in this country.
Okay. Well, thank you so much for answering my question.
You're welcome.
Okay.
Okay, so I'm going to make an announcement. We went way over time. So we'll give extra time to start about 1:10. And I will go ahead and send an email blast out for those who already left for lunch to rejoin us at 1:10.
Okay, thank you. Bye-bye.
See you then.
Bye.